So I'm really excited about the data from the INSIGHT mutant calreticulin antibody. And I think what's so impressive is not only the reduction in the platelet count, but even more so the reduction in the megakaryocytes, specifically the mutant megakaryocytes in the bone marrow, and the calreticulin variant allele frequency. So in my perspective, the data really is much better than one would have ever anticipated. What data I'd really like to see moving forward is what happens when the antibody is discontinued. Do the mutant calreticulin megakaryocytes come back and the VAF increase? But the data presented thus far has been absolutely impressive. So I think with the data that we have, it's a little difficult to identify when somebody should be given single agent antibody, single agent ruxolitinib, or the dual agent. But what I think is informative is the combination of both can further reduce spleen size and symptoms. In terms of side effect profile, one thing that may be important to note is that both ruxolitinib can reduce platelet count as well as the calreticulin antibody. The purpose is to reduce platelet count. So I think it is very important to very intensely monitor CBC to identify any significant reductions in platelet count below the normal range. Purpose for treatment and the issues that are important in myelofibrosis, we've got many different issues, namely spleen size, symptoms, and also anemia. So having something that will not only address spleen size, symptoms, and anemia, as well as really address the root of the problem, namely reduction in the mutant burden, is extremely impactful. One of the pieces of data that is most impressive is the brisk reduction in the mutant calreticulin allele burden. And to put it into perspective, really in this MPN field, there are very few agents which have the ability to reduce mutant allele burden. Our JAK inhibitors, although very effective in terms of spleen size reduction and symptom burden in our myelofibrosis patient population, don't have a significant impact on the allele burden. Obviously, a reduction in the allele burden is very informative. What would be critical to evaluate is this durable? Number one, if you remove the drug, calreticulin mutant allele burden just come back up? And if so, at what tempo does it reemerge? The initial data from the presentation is extremely optimistic. It's demonstrated that the antibody very successfully reduces platelet count, at least initially does reduce calreticulin allele burden, and reduces the mutant megakaryocytes. In terms of other things or, more detailed analysis that I'd like to see moving forward is actually the stem cell compartment. And that would really then identify or really determine whether if you get the mutant stem cell compartment, which is the stem cell reservoir for the disease, therefore one would expect some, quote, cures. So I think only time will tell. And I think it would be very informative to see what happens when the antibody is removed. Does the allele burden continue to remain down, or does it rise? I think those are very, very interesting and informative questions.